A very good evening to you all. It's indeed my privilege to be a moderator for this panel discussion on Code Blue events in non-ICU setups, a must-stop chaos. I'd like to welcome all the esteemed panelists who have taken their time out of their busy schedule to join this panel discussion. Recognizing and responding to deteriorating patients is very essential. It's very, very essential for preventing or mitigating the morbidity and mortality in any healthcare setup. Hospitals across the globe have implemented Code Blue activation calls to handle such critical situations, like for cardiac arrest. However, in spite of all the protocols in place, whenever there is a deterioration of a patient in a non-critical care area, there is utter chaos. And that's why this topic is very, very important for all of us to know. And in this discussion, our speakers will be touching upon why this chaos happens and how it can be prevented, and the role of RRT and the importance of nursing in such critical situations. As the time is limited, I request the panelists to adhere to the timing, and we'll be having 2 rounds of questions. My first question is to Dr. Padmaja, HOD Anesthesia from NIMS. Dr. Padmaja, I would request you to highlight the systems in place to prevent Code Blue events in non-critical care areas in your hospital.
Good afternoon, everyone, and it's a pleasure to be on this panel. Thank you, Bobby. I think I belong to an academic medical center, unlike, I think, from what I've heard in the evening, a lot of you belong to the corporate hospitals, but I think your roots are still in the public hospitals where you're trained from, and you understand how chaotic the wards are. So to bring these systems in place, I think I'll start with that time when we try to systematize this chaotic situation to a more organized sector, looking at the safety and the quality indices. So I think this probably, as you understand, it happened earlier in the corporates because of the NABH accreditation, but then this concept came in very late into the public sector hospitals. So for us to standardize this or to prevent this, as we all know, the Code Blue in the ward is probably a never event. That is something that should never happen. And this would usually happen because either we are in a hurry to shift an unoptimized patient to the ward because of the need for the ICU beds. And as we know, these wards are usually the unmonitored areas. So unless we have a system in place, we cannot prevent this. So ours is a 2-tier system where we have the nursings monitoring the patients, and there are also residents who are under training monitoring the same. So we started with training these nurses and the residents to recognize these early warning systems. And this again took quite a lot of time, and probably it's still underway. So we haven't achieved that mark of having people recognize these early warning signs. And also, I think until DOSI was installed in the hospital, it was all manual monitoring. And so to identify those patients who required more frequent monitoring by using this new scale took some time for us. So this actually changed a lot of things for us once we have started implementing the new score in the wards. And also so that the nurses as well as the residents understood which patients require more frequent monitoring and which patients can probably be left unmonitored. So this new score has made a lot of change and to the incidence of these Code Blues in the wards. So the next thing that made a difference was having this rapid response team, where so one of the most important change came from when we could empower the nurses to call the rapid response team directly. So until then, being an academic institution, there was a lot of hierarchy in calling. So the nurses had to inform the resident had to inform the senior resident had to inform the faculty. Then they would take a call to either shift to the ICU or probably do whatever is required to resuscitate the patient in house. So when we could break this hierarchical system and empower the nurses to be able to call the rapid response team directly, that made another change in reducing these code blues in the wards. I think these were the two systems that really made a difference. The other is again being able to monitor the patients in the non-ICU areas. And I think that is where we are talking about DOSI today. I told DOSI that I will not talk about DOSI on the stage, but still I can't help talking about it because that did make a difference, that being able to monitor the patients in the non-ICU locations without having to spend too much time on monitoring. I think the patients would be monitored manually, but then being able to monitor without actually spending time on it makes a lot of difference to reducing these never events in the wards.
Thank you so much, Dr. Padmaja. Dr. Padmaja highlighted on the importance of empowering nurses and the residents to take immediate action to prevent such situations and to handle patients in critical situations, and also the importance of training which is required to handle to prevent code blue situations in non-critical care areas. My next question is to Dr. Sateesh Kumar. As I had already mentioned, irrespective of protocols in place, when a code blue is announced, there are a lot of, all these accredited hospitals have a lot of mock drills in place. Regularly, every month they have. Irrespective of all that, when a real code blue happens, the situation becomes chaotic. Either the team doesn't know the place, exact place where it is because the announcement was not made right, or the crash car doesn't arrive on time, or the person who's there doesn't know, the first responder doesn't know what to do, so much and so on. So my question to Dr. Sateesh is that, why such chaos happens irrespective of protocols in place for code blue or med calls in hospitals, and how effective utilization of rapid response team or critical care outreach team help prevent code blues in non-critical care areas?
You are answering my question also. See, yes, we have protocols where on books and papers, in the monitors, in the desks, everywhere in the apps. But when it comes to the real scenario, every patient is different, especially patients who are in the wards are different when compared to the emergency departments and ICUs. Patients will be stable. If you see sudden cardiac deaths, sudden cardiac arrest happens in non-critical areas because the monitoring is not that much as we can expect in the ICUs. Though we have, see, if we have 100% perfection, we will not have every monthly meetings because there is nothing to talk. Yes, if there is no meeting minutes will be there. Yes, definitely. Because if for a code blue event, to talk as a code blue event, it is a lot of things, lot of people will be involved in this act. First, in identification, what is the attrition rate of nurses? We have to train nurses every time, every month, every quarterly, every hour we need to train. Once the alerting, identification, then alerting. One day the PA system will work, the second day PA system may not work, the second. And getting a crash cut. Crash cuts, most of the hospitals may not have in each floor. They have to get everybody in the hospital, every team player of the code blue should know the access to the place where he has to get the crash cut. Every floor may not have a defibrillator. Every time, still we have a committee meetings that we should have a defibrillator, but it may not be possible every time. And the code team arrives. Team changes because I can't be at hospital 24/7, 365 days. Every human is different. Their thoughts are different. Though checklist is same, but kind of act is different. So regular trainings, protocols, though are in the place, they should take that into the heart. They should have a passion to treat the patient when there is a code blue in the wards. Yes, I agree. Protocols, mock drills, I can explain mock drills. When there is a mock drill, everyone want to go and give the best. Most of them, they'll go, they'll see it's a mock drill, they'll come down, because it's a mock drill. Because they should feel it is a drill, it's an actual event, they should act. So these trainings must and should happen at regular intervals to prevent the chaos during code blues. Rapid response team or med call teams, yes, but as we know, the doctor, nurses to the patient ratio, very, very less. So it's a public sector, a private sector. We need more trained doctors. We need doctors first. We need more trained doctors then, because the ratio is very, very large. So we have to. A doctor cannot go and see the medical doctor or a doctor cannot go and see all the 200 patients in the hospital at one day or one shift. He should know which patients are sick. If he want to know which patients are sick, the nurse should be trained. If the nurse, because 1 is to 1 is to 20, 1 is to 30, the nurse how they are seeing patients. These documents, these vitals, if it is available to the doctor before in hand at the earliest, so then we can prevent the code blues. I think early warning signs is the best tool. That is the modified early warning score which we use in our system. Hospital which use that EMR, I think it's very, very beneficial that the doctor can see in his mobile that patients have which are in the red. He can go and visit first, then he can go to the green and yellow patients. Otherwise, if he can't trace the patients when he enter the hospital, it is chaos. He cannot prevent the code blues at any point of time.
Thank you so much, Dr. Sateesh. As Dr. Sateesh mentioned, for the effective utilization of the rapid response teams, the nurses have to support by intimating the critical patients in their wards. Proactively, the rounds have to be carried out by the rapid response team members to assess the condition of the patient, so that if any patient is deteriorating, they can transfer the patient to the ICU than waiting for a code blue to happen. So thank you. My question to Dr. M. Prakasamma would be, what is the role of public health to avoid panic situations like code blue?
I have to say that I don't know whether I have any legible right to be here, because I'm neither working in a hospital, nor am I an owner or an administrator. I'm not a doctor, not a medical doctor. I don't have claim to be a nurse also. So I'm a public health professional. So how I see things is slightly different. So I hope you will bear with me. As a public health professional, I can only say that we had gone through a national chaos, code blue countrywide. And that is where we all need to come in. It's not just one patient, one hospital, but the entire country of more than a billion people who went into this situation of code blue, and the chaos created by an epidemic, a pandemic, how it threw our country off balance. We have a very large public health system in India. In fact, I had to argue with many countries that ours is one of the best systems, is one of the best public health systems. Everything is there, down from the village level to the tertiary level. We have the best doctors. We have almost every technology coming into India. We have nurses who go all over the country and serve, the best technicians. However, we went into a chaos. And the chaos and how to deal with it. Of course, talking about public health in this group, in this forum, would be very difficult, and therefore I selected only 3 or 4 points. The first point of this is that during this chaos, home is where health starts. It's where nutrition starts, where caring starts, where the mother looks at signs and symptoms and goes for care, where she takes care of what the baby or the children and the other older people eat. It starts there. Health is at the home level, at the family level. But gradually, treatment moved into the homes. Initially for communicable diseases, long-term diseases like TB, malaria, and now, of course, even NCDs. The government has put NCDs as follow-up and taken it into the home. Now with COVID, we have technology going into the homes. Not simple technology for like temperature, but complex technology, like even monitoring oxygen saturation, having mini ICUs in the home, oxygen concentrators. The public suddenly became tech savvy for their own health. They wanted to go and look at everything. How do I get better? How can I buy 2 oxygen concentrators and keep? I have 2 old people in the village. They may come to the town. This was the panic that was created. As I said, I will not go into details of what public health actions, what mistakes we made, how we failed as a country, but only to say that the first and the most important was the health workforce. I have been for a long time a part of the Global Health Workforce Alliance of the WHO. And I have seen how, of course, many of you who spoke mentioned about the doctor-nurse-patient ratio. You didn't speak about the doctor-nurse ratio. Both are equally important. If for one doctor, you need 3 nurses. For one specialist doctor, you need 5 nurses. Because the nurse is round the shift, round the clock, and also because the nurse has to do more intense work for a longer time than the doctor. So there are 2 ratios that are very necessary, and our country has actually failed very badly. While we export doctors and nurses and who perform miracles in other countries, we have not been able to manage our own health workforce, either in numbers or in skills or in accountability. None of these. And I'm talking about the public health system because I've been part of that. And even today, I'm a member of the AGCA, the Government of India Advisory Group on health. So this is one, the health workforce management that needs to be done. India has to put its act together. This task specificity, you said, about the Code Blue Bear and the Ferrari team, everyone has a role. The one who does this, and that's why it's so efficient. That role clarity is still not there in our health workforce. What does the nurse do? Overlaps with the doctor. What does the doctor do? The general duty doctor's role overlaps with sometimes the specialist doctor. There's so much of overlap and therefore confusion. I feel that's the first thing that needs to be done. You have to tell me 1 minute before. Huh? I tend to go on. I'm very sorry. I've been a speaker for a long time, many years, so it becomes a little difficult for me to put things in 1 or 2 sentences. The second point I wanted to talk about is the lack of integration in our system. During the COVID, it came out very clearly. Our PRIs didn't work with our public health systems. PHCs and Panchayat Raj systems didn't work together. Women and child welfare, Anganwadi systems and sub-centers didn't work together. Even today, we don't have an integrated health system, an integrated intersectoral coordination in health, and that's been a major problem for us. I won't go into experience. I've written a lot of points, but I won't go into that. Thirdly is the communication. Recently, we computed answers. My team did a review, quick review of all the communication that went to the public during the COVID. And let me tell you, it has been a really chaotic communication that went. What should they do? What should they take? When should they go to the hospital? Which number they should dial? I'm talking about a small village in some remote corner. What do they do? Where do they go? Therefore, in chaos, what they do is they don't allow the health worker to go and give the messages that are required to be given. They barricade, the whole village is barricaded, they don't allow. This is because of the chaos that was created and the poor communication. I do have the report. If anybody is interested, you can approach me later. Now, the public health system's return referral. The referral itself is not a very efficient system, but the return referral, that is, when a patient is better and goes back, who follows up the patient? I was so amazed by listening this earlier today about the home care system in Apollo Hospital because I met the lady in charge of it, and I said, fantastic. In 1991, just after my PhD, I said, okay, let me do a study to see how much health care or technical care does a patient require after discharge from hospital, and which patient requires how much care. A cardiac patient, a stroke patient, a cerebral stroke patient. And at that time, I tried to put in place this home visiting by partly technically qualified people to take care of people at home after discharge, because cost of hospitalization was going up even in 1991. And then I found I've not been a success in that area. Maybe I don't have very good business skills or efficient management skills, but I want to congratulate the Apollo team who's doing this. This return referral, even today, is a failure in the health system. If there is a delivery and a birth, and the woman has delivered in the mother's home, maternal home, but goes back to the husband's home, in-law's home, how do you manage this? And I hope there is an answer in technology. Finally, just one point I want to say is about home care. Home care is the answer, I think. If you can take this home care in a very systematic manner, a large manner, all the technology that you have at your hand, if it can go to the homes, I feel that's one of the ways in which public can be educated, become more aware, and become self-reliant in their own care. I'm sorry, did I take a lot of time?
Thank you so much. No, you have added to the timelines. And thank you, Dr. Prakasamma, for highlighting the importance of home care to prevent such situations and also the roles and challenges in public health. When we see a code blue activation or activation call in a hospital, the code blue team, sometimes there may be one team, sometimes there may be two teams coming from different areas, and they have to reach within 3 minutes, and then the patient has crashed. They start resuscitating the patient maybe for 10 minutes, 5 minutes, 20 or 30 minutes, and if the patient survives, you can see a joy on their face. And all said and done, there's tremendous pressure on the code blue team. I would request Dr. Padmaja to please highlight the psychological impact of a code blue on the team and what measures can be put in place to mitigate the stress of a code blue team. Over to you, Dr. Padmaja.
I think I've been on the code blue team, and I know it's really, really stressful to be on that, because you're called for a very responsible job to, to revive someone who is arrested. One of the major stresses is that you do not know whether the person who is there in the ward has already started doing something, or they're just waiting for you to arrive. So I think one thing that can actually mitigate this stress is that if we can train our nurses to start the CPR while the code blue team is arriving, rather than wait for someone to come in and revive. I think that training has really led to a significant reduction, because you know that someone has begun the care and you're likely to go in and continue with that. The other thing that really stresses us out is the, as I said, the non-ICU locations where you're called and you're not sure whether the availability of the required drugs or equipment is there or not. So sometimes, like I, as a professor now, ask my residents to carry the necessary drugs with them, rather than to really, if it is not available at the site, you should not be panicking there. So they carry a small bag with them, which has the drugs and the equipment that's at least required to resuscitate and intubate. So having these systems in place, as Dr. Sateesh said, in every location, presuming that every location is a potential area for a code blue, is another important thing. The next stress comes from the non-code blue calls, or rather a panic calls that we receive a lot of times. Like even if you look into the literature, about 50% of the calls are for non-blue code blue. And this is because obviously it is not to stress out the code blue team, but it is because of the care that the person who is there in the ward has for the patient. So there are a lot of false calls that we get, especially when the patient has, like say a syncope or maybe a seizure or something, and then instead of calling the rapid response team, the code blue team is called. So having the people there identify when to call the code blue team and when to call the other team probably reduces the stress or number of unnecessary calls to the code blue team. And these usually happen from locations where people are not really aware of the clinical situation. Like in the wards, probably the nurses are trained, but in areas like maybe the labs or the radiology suites, where people don't see these clinical situations very often, you get a lot of false calls. So probably training people on when to call the code blue team, and then probably what to do while the code blue team is arriving, and also having systems in place for the code blue team to start acting are few things that can reduce the stress. But still, whatever said and done, doing a CPR is still as stressful. Even after 30 years of my practice, I think I'll be going through the same stress as I did soon after my MBBS. So probably being on the team is stressful, but there are a few things that we can do to mitigate that.
Thank you so much.
Just one thing that, like, if we feel that at the end of that thing, I have done my best and I could do what I could, irrespective of the outcome. If that feeling comes through, it need not be a successful outcome, but still if I don't go back thinking that I could have done something better, probably that reduces the agony of the person who is on the code blue team. Because not always this resuscitation is successful, but at least we shouldn't go back thinking that maybe I could have done something else for this patient.
Thank you so much. As Dr. Padmaja has mentioned, to a certain extent, stress can be relieved, especially in non-critical care areas, not the wards, but in places like an X-ray department or a physiotherapy department. When a patient collapses, those staff working there, the technicians, also should be trained well to respond first. So if they start initiating the resuscitative measures, so it will become easy for the Code Blue team members when they arrive. While the doctors are in command, it is the nurses who execute the care plan. But often the nurses, the role of nurses is not given its importance, or nurses are not empowered, as Dr. Padma mentioned initially, that, to escalate the call or to take action on their own. So what is the importance of nursing in critical patient care situations? My question is to Dr. M. Prakasamma.
Okay, I have not been in clinical field for a long, long time, except my only clinical experience is in 1976 to 79, and I enjoyed it. I really, unfortunately, I couldn't remain in nursing. Today, when all of you were, given applaud, I was so happy. I said, as though I'm getting all those awards, all those certificates. So kudos to all the nurses. I just want to say that the nurse in a hospital is the heart of the hospital. I don't see anyone else as the heart of the hospital. Perhaps the doctor is the head, perhaps the in charge, the owner is the financier or whatever. But actual heart, who goes out, who comes in, they come for treatment. Who goes out, they go happy because of good nursing care. This has been my very firm belief right from 1972. Unfortunately, I've been using all my 40, 50 years to instill this, take this message across, and I don't think I succeeded either with nurses, doctors, or policymakers, or ministers, or anyone. However, this morning somebody said that a surgeon's head should go to the hand through the heart. Someone said this. When I talk about this, 3 H's of nursing, the head, the heart, and the hand, for a surgeon, in 100%, maybe many people tell me he needs 48% head, 48% hand, maybe 2-3% heart. But a nurse, I'll not go into all the examples, but a nurse needs equally 33.3% head, heart, and hand. This is the complexity of nursing. This is the role of nursing. And if that nurse is able to do that, I think that's what more than 50% is. And that's what I see today, the 2 partners, the FE and Dozy, doing that great job of at least acknowledging that nursing part. I also see the 3 C's of nursing. A nurse is the only person who does everything else, everybody's job. She is not just the caretaker or care provider, which includes caring and technology both. She's also the manager and coordinator of patient care, whether it is reports, whether it is getting things done in time, calling for the doctors, or whatever it is. I'll not go into detail, there's no time, but she's the coordinator of patient care. She's also the custodian. That's why so many nurses get into trouble, because the patient fell off the bed or patient left without informing or something happened. She's also the custodian of the person, the human who comes to the hospital. That means till that person goes out, whatever happens, it's actually the nurse who's blamed and given credit for. Now, about this critical situation and technology. Technology is very, very attractive. Someone also said that. It is glamorous. So everybody likes to use technology. Beautiful new machine. Yes, I've been put there, and they're very happy with that. It is also prestigious to work with modern machines and things. Therefore, also it is automation. But there is something, the critical core of nursing, that no machine can do. I will tell you about a book, Christy Watson's, So Difficult to Define Nursing. And it's been all textbooks I've been looking at also. It's very, very difficult to say, this is nursing. This Christy Watson's book calls nursing, after all her experience of writing, thinking, reflecting, she says it's the language of kindness. That is what nursing is. The warm smile, the soft touch, the kindness in the eye. Sometimes when you have technology, that 2 minutes at the bedside to check TPR is the time that she has that eye contact with the patient. It is the time that she touches the person. It is the time for that warmth. It is that humaneness and human touch. And I think that is what, in any critical care situation, any amount of technology, it is what has to be nurtured and kept protected, valued in every hospital, because that is the heart of nursing.
Thank you so much, Dr. Prakasamma, for highlighting the care and compassion and the tender, loving care which a nurse provides, which cannot be replaced by technology. Thank you so much. And my last question is to Dr. Sateesh Kumar. Dr. Sateesh, could you please share your views on the role of technology in preventing code blue situations in non-critical care areas? Just 2 minutes, please.
Yeah, okay. For a minute, I thought I was in a nursing
I got a cheat from the organizers that we need to wrap up, that's why.
Yeah, yes. I don't understand. See, we are in digital world, yes. If you go to the flower shop, thanks to COVID, it make our work more digital actually. If you would go to the flower shop, now we are paying, usually pay to the phone pay, which we get cash. Now we are giving a phone pay. But time is investment there actually. See, if she or he wants to know whether you paid or not, you have to show that. Now the technology is changed now. There is an audio, he paid 20 rupees. So it is changed actually. So while listening, she can serve another customer. Is it right? At the same time, if a doctor or a corporate doctor or a corporate team member, he knows, if he invests his time rightly, if he knows what is the problem, where exactly the problem, if he has a command center room in the hospital or in his place, where I can see a monitor where the sickest patients can be alarms can be visible there, and I can direct the nurses or the doctors, which the patients can be transferred from the wards to the ICUs, or a RRT team member can go and see the patient. And at the same time, this message should go to the consultant, the primary consultant, or we have to keep the primary consultant always in the loop that where the patient, each time the patient, doctor or nurse will change, where this patient is a treatable patient, a salvageable patient, or a non-salvageable patient, the primary consultant knows better than us. So if an app or a technology which can help a doctor, duty doctor or a corporate team member and the consultant, if they are in the one loop, usually we follow WhatsApp for everything. But how bad it is also, I don't know, because we usually take ECG, CT scans, MRS, what else, everything. Now we are using WhatsApp for the communication. But it may not be the right platform for everything for the privacy. If you have a technology that I can see the patient, all the sickest patients in my room sitting in the hospital, and I can direct my nurse or doctor, and I can connect the consultant, primary consultant, in the same platform, that will be easy, and we can prevent a lot of code blues. Code blues should not happen if strong RRT team is there in the hospital. Code blues should not happen if there is a strong technology which enables the streamlining of these three doctors, nurses, and the consultants are on the same platform. So I hope there are multiple partners, multiple technologists are there to help in this, in providing these platforms. I think those hospitals running the EMR actually, it is very much useful for them, because one app or one scoring system, if it is there in the EMR already, so it is automatically it enables the doctor or command center specialist so that he can identify the problem and he can prevent the code blue. Thank you.
Thank you so much, Dr. Sateesh. So I'd like to thank all the participants, all the panelists for their wonderful participation. And throughout the discussion, the highlight would be that people, processes, and performance are equally important for preventing such situations in non-critical care areas, and technology definitely help detect this deterioration of patients earlier, and it will help the healthcare team members to act upon and to prevent deterioration and also to prevent code blue situations in non-critical care areas. Thank you all so much.